This is a very important question because we know that most of the patients who are assuming TKI are bound to assume the TKI for the rest of their life. There is the possibility to discontinue this therapy, but this is limited at the moment to 20-25% of the patients. So I would say a quite limited percentage of cases. And so we know to need exactly which are the long-term toxicities of the TKIs. And among them, what we fear most is almost certainly represented by the risk of cardiovascular events that they are introducing. This is different from TKI to TKI. And the other point, which is very relevant, is that, of course, is dose dependent. And so we were used previously to use almost fixed dosages of each TKI. And we are going at the moment to use more patients tailored dosage, or at least the tendency is to decrease the dosage of the TKI. And the second point is we must correct, because what we know is that there is an addition of the effect in terms of risk of cardiovascular toxicity in patients who are already predisposed to have this kind of events, and therefore we need to correct, when possible, of course, all the style of lives and also the metabolic alteration that can, of course, help to increase the toxic effect. The second point, which is extremely interesting, is important, I would say, is certainly to have the possibility to monitor these patients. And the number of the patients with CML is progressively increasing because they are, fortunately enough, surviving almost as the normal population. And therefore, being the incidence the same, but the persistence and the number of the total CML population is progressively enlarging. And they need a continuous monitoring not only in terms of molecular monitoring, but also of their clinical conditions. So we need to predispose a number of analysis or examinations, which, I would say, for also not only about the disease, but mainly about the toxic effect that can be related to the therapy of the disease, in particular these cardiovascular events. So a number of I'd say tests should be done at diagnosis and repeated regularly, depending on the type of test, of course, during the course of the disease. This, of course, will increase the cost in terms of personnel, in terms of not only the cost of the drugs is the minimal part at the moment, is all the apparatus. That's why we need, of course, to push also for increasing the percentage of the patients that after a certain number of years at least can be defined as cured. So they do not need any further or so frequent follow-up as at the moment it's occurring.